Guys, my name is Christina Williams, and I'm doing my presentation over bipolar disorder in children. So bipolar disorder is most common in adults with onset around age 18, but it does present in children and adolescents. I chose to focus on children aged 13 and under for this assignment. I wanted to learn more about the diagnosis because I've been really wary of diagnosing children with mood disorders or conduct disorders, or even things like ADHD, just because they are still growing and developing. They are more sensitive to situational affect and trauma. On the other hand, I do understand that some people have brain abnormalities that can make it very difficult to function. And so that diagnosis and medication and all that is really necessary. Prevalence in children is around 2% of the general population, though it's not well established due to debate on the appropriate definition of boundaries of diagnosis. Also, children of the same chronological age are not equal developmentally, so it's really hard to pinpoint where things begin and end on some of these things. A family history of bipolar disorder is the strongest, most consistent risk factor. Suicide rates are 15 times that of the general population. It's estimated that out of all suicide attempts, maybe as high as 20% are related to bipolar disorder. There are different types of bipolar disorder, so we'll talk more about those in a minute. So for the DSM diagnosis, the first part of that is going to be a manic episode. That's going to be a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased goal-directed activity or energy, lasting at least 1 week and present most of the day, nearly every day. During this period of mood disturbance and increased energy or activity, 3 or more of the following symptoms, or 4 if the mood is only irritable, are present to a significant degree and represent a noticeable change from usual behavior. That's going to be inflated self-esteem or grandiosity, decreased need for sleep, being more talkative than usual or feeling the pressure to keep talking, flight of ideas or a subjective experience of thoughts that are racing, distractibility as reported or observed, increase in goal-directed activity or psychomotor agitation, excessive involvement in activities that have a high potential for painful consequences. Mood disturbance is sufficiently severe to cause marked impairment in social functioning or to necessitate hospitalization to prevent harm to self or others, or there are psychotic features. The episode is not attributable to a physiological effect of a substance or another medical condition, such as a really high fever. The next part of a bipolar diagnosis is going to be a hypomanic episode, and that's a distinct period of abnormally or persistently elevated, expansive, or irritable mood that's abnormally and persistently increased activity or energy. It lasts at least 4 consecutive days and is present most of the day, nearly every day. In this period, you're going to have the same symptoms as listed on the previous slide, 3 or more, or 4 if the mood is only irritable, and those are going to be persistent and they represent a noticeable change from usual behavior and have been present to a significant degree. The episode is associated with an unequivocal change in functioning that is uncharacteristic of the individual when they're not symptomatic. The disturbance in mood and the change in functioning are observable by others. The episode is not severe enough to cause significant impairment in social functioning or to necessitate hospitalization. If the psychotic features are present, then the episode is manic. The episode is not attributable to physiological effects of a substance or other medical condition. And the last part is going to be a major depressive episode. The last part is going to be a major depressive episode. So that's going to be 5 or more of the following symptoms have been present nearly every day during the same 2-week period, and they represent a change from previous functioning. At least one of the symptoms is going to be a depressed mood or the loss of interest and pleasure. So depressed mood for most of the day, nearly every day, as indicated by either subjective report or an observation made by others. Marked diminished interest or pleasure in all or almost all activities for most of the day. Significant weight loss when not dieting, or weight gain or decreased or increased appetite. Insomnia or hypersomnia. Psychomotor agitation or retardation as observable by others, not just them saying that they feel run down. Fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate or indecisiveness, recurrent thoughts of death, suicidal ideation without a specific plan, or a suicide attempt or a specific plan for committing suicide. The symptoms are going to cause significant distress or impairment in social, occupational, or other areas of functioning. And the episode is not attributable to the physiological effects of a substance or to another medical condition. The type of bipolar diagnosis is going to be based on the severity and duration of symptoms. So for bipolar 1, the criteria have been met for at least one manic episode. Bipolar 2, criteria have been met for at least one hypomanic episode, and there's never been a manic episode. Cyclothymic disorder, for at least 2 years, they're going to have symptoms but don't meet the criteria for a full manic, depressive, or hypomanic episode. Children are going to present a little bit differently than adults, so symptoms are going to be a little bit different. For depression, it's not just sadness, loss of interest, but also pain, such as frequent headaches or stomach aches, the failure to make expected weight, but especially irritability and anger. For mania, we're going to have extreme irritability, rage, explosive mood swings, psychosis, poor social functioning, which can mean poor judgment, recklessness, substance abuse, or sex-based activities. Depression may manifest as anger and irritability in children and adolescents. Therefore, it's going to be difficult to determine whether it's actually bipolar disorder or if it's going to be just unipolar depression. Symptoms of mania and depression are often going to appear intertwined. So it's not going to be episodic as it is with adults. They can go back and forth with symptoms. They can even occur at the same time. So it's a little bit different than with adults. It's important to differentiate mania from other disorders that are commonly diagnosed alongside bipolar disorder, such as ADHD, depression, conduct disorder, oppositional defiant disorder, or other kinds of psychosis happening in the brain of a child with bipolar disorder. As an overview, brain structure abnormalities are going to play an important role. As you may remember from the video that we watched, a normally functioning brain will prune away those pathways and synapses which aren't needed so that it can strengthen the ones that we do use. In a person with bipolar disorder, that doesn't happen. Neurotransmitters such as norepinephrine, serotonin, and dopamine are kind of running wild and disrupting the brain's reward system and its ability to function properly. This disruption and those overactive synapses can cause a lot of distortion and illogical thought patterns that contribute to both mania and depression. Okay, so neuroimaging shows that diffuse gray matter and abnormalities, specifically volumetric changes to the anterior limbic network, that includes the prefrontal regions, thalamus, amygdala, hippocampal complex, and the midline cerebellum, are present in those with pediatric bipolar disorder. The Rubin-Falcone study even suggests that regional gray matter volume can be used to differentiate between bipolar disorder and major depressive disorder, even before the appearance of a manic or hypomanic episode. That was really cool because it really shows the impact of brain structure on these types of disorders. Lateral abnormalities in white matter connectivity of brain regions and neural circuitry that are critically involved in emotional regulation and sensory processing have been reported in people with bipolar disorder. This study right here found or suggests that a response to lithium treatment in pediatric bipolar disorder is associated with the normalization of white matter microstructure in regions that are associated with emotional processing. And so, as you'll hear about in just a second, lithium is kind of like the gold standard mood stabilizer for bipolar disorder. So this really helps to show you why that is. So medication for bipolar disorder is definitely the first line of treatment. And they'll probably start with second generation antipsychotics such as Abilify, Seroquel, Zyprexa, or Geodon. Those are going to help to balance out the effects of mania. They also may use mood stabilizers such as the lithium. That's kind of the number one go-to thing for bipolar disorder. May also use anticonvulsants such as valproic acid or Depakote, Topamax, things like that, even though they don't really have strong empirical evidence of positive results. So those are kind of used if everything else isn't working. So for the second generation antipsychotics and the mood stabilizers, the main side effects of those are going to be like fatigue and nausea, maybe some weight gain. If you have more serious things such as diarrhea or constant vomiting, then that's going to be a medical emergency and something that needs to be dealt with right away. It's really recommended that people with bipolar disorder and on these types of medications keep a daily log, not only of their bipolar symptoms, but also side effects of their medication and what's working and what's not working so that they can figure it out, because everyone's going to be different. And some people do need a different combination of medication. It's important to figure out what works for you. If the depression symptoms are prominent, then a doctor may choose to add an antidepressant. Selective serotonin reuptake inhibitors are known to make mania worse or to induce a manic episode. So that's going to be like your Prozac and Zoloft, the basic antidepressant things. So they will probably use a short-acting antidepressant such as Wellbutrin or low-dose Effexor XR have been used. Something else that's showing promise for things like bipolar disorder and ADHD is omega-3 fatty acids being used alongside other medications. For co-occurring disorders such as the ADHD, it's going to respond to treatment only if the bipolar disorder is treated first. So they're probably going to start with the second generation antipsychotic and then add a stimulant or a tricyclic antidepressant along with that. Other common co-occurring disorders like conduct disorder or oppositional defiant disorder are going to be treated with the second generation antipsychotics or the mood stabilizers. So those are really going to be treated with the same kind of medications. As a counselor, you may choose to do the individual counseling, but with a child with bipolar disorder, it may be better to do a family-based approach so that you can kind of bring everyone in to work together on managing symptoms and things like that. So specifically right here, I did child and family focused CBT. And so that's really been shown to improve parenting skills and coping, family flexibility, family positive reframing, and it's shown promise as a mediator for child mood symptoms and global functioning. It's recommended also for use as preventative in high-risk populations to improve the family system functioning and hopefully lower expressive symptoms of bipolar disorder in children. So child and family focused CBT is a 12-session protocol-driven treatment program. It alternates between child, parent, and family-focused sessions. It's also been adapted into a group format that's going to consist of 60-minute parallel parent and child groups and a 15-minute multifamily child and parent combined component. In both, treatment is structured around 7 core components, and that's going to be using the acronym RAINBOW. So first is going to be focusing on routine, establishing and simplifying routines. Next is affect regulation. It's psychoeducation about affective circulatory dysfunction, monitoring moods, and developing cognitive and behavioral coping skills to manage triggers. I Can Do It is going to enhance self-esteem and self-efficacy in the child and the family. No negative thoughts. And Live in the Now is going to be learning cognitive restructuring and mindfulness techniques to decrease negative and distorted cognitions. Next is be a good friend, and then balanced lifestyle for parents. It's going to promote the child's social skills and enhance balance and self-care in everyone. W is ways to get support. So it's about accessing support within the family, school, and community. And then some things that were kind of important in that is going to be, psychoeducation, just helping the child and the family and everyone understand what bipolar disorder is, how it affects the brain, and why medication is important and why you should follow the treatment plans. Also emotional regulation. So you could teach calming techniques such as deep breathing or anything like that. Any mindfulness techniques would be good. Also symptom management, that's going to include what we previously talked about, keeping a log of, your symptoms and medication side effects, just making sure that everything's written down so that your doctor can help you figure out what's going to work best for you. So for referrals here in Waco, we have the Claris Center for Families. It's part of MHMR, so you do have to qualify for their services. There's also the Family Health Center. It's based on a sliding income scale. And there's also private practice psychiatrists. I couldn't find a lot that are specifically for children, but I did find Dr. Christina Chen. And I would really encourage my clients to find someone that they like and that they can work well with, because that is their decision. But I would want them to see a psychiatrist instead of just the primary care physician, just because it is going to need that specialized care. You're going to need someone who knows a lot about the mental health aspect of it. It's not like treating anxiety or depression. It's really a complex thing. And these are my references if you want to check any of those out. Thank you for listening.